I'm Chris Fanta. It's my great pleasure to welcome you to our asthma grand rounds today, including those of you who are joining us by live webcasting. And we have what promises to be a terrific program today that will explore the different interrelationships between obesity and asthma on a variety of levels. And we have an expert panel to discuss this topic, all of whom have published on this topic. And I'd like to introduce them to you in the order that they will be presenting, beginning with Dr. Bernard Kinane, who is Chief of the Division of Pediatric Pulmonary Allergy and Cystic Fibrosis at the Mass General Hospital for Children. And Dr. Stephanie Shore, who is a Senior Lecturer on Physiology in the Department of Environmental Health at the Harvard School of Public Health. And Dr. Kelan Tantisira, who is claimed as a member of both the Pulmonary and Critical Care Division and the Channing Division of Network Medicine here at the Brigham and Women's Hospital. And I do invite you, before you leave today, those of you who are in the audience, if you might fill out your evaluation forms, that would be terrific. So we're going to begin this morning with Dr. Kinane, or this afternoon. Thank you.
And thank you for inviting me. It was fun actually preparing for this. I have no conflict of interest. I shall stay my usual. Now this slide is familiar to everybody, and you see it a million times. And this is, this is looking at the incidence of obesity in the United States. And you can see white. White means a low incidence, no data or less than 10%. But you see as we go up to 2010, we're becoming more and more red. And what's good news is in younger children, it looks like obesity is leveled out for the first time. So all good. Now, this just to prove that we're on the bad end of this list too. From the obesity, we lead the world. There's some exceptions, of course. But clearly, the United States and Mexico are top of the list, and Scotland coming in there third. So it's an ongoing problem, just to give the backgrounds. Even countries now that you would have thought we had excellent statistics and should do much better, France is now coming in at 11.2, and it's interesting to see how things have changed even there. They're on a slope as well as we are, but maybe not reaching the same level. I don't need to show this to this audience, but just as introduction, it's kind of interesting to look how I made the last slide red. The last slide was red for up here in the United States, and you could almost say the same is happening here. We're red in asthma as well. So clearly an overlapping picture. Now, the reason why I got into this was, and I just wanted to show a slide from our clinic just to see how we became interested in this. We started noticing about 5 years ago that the kids that are showing up with new onset asthma were more likely to be obese. And it was really obvious in the clinic, so much so that we have a weight management clinic within pulmonary because of this problem run by my colleague, Christina Sirica. So here's, just to give you an idea, and we thought this was bogus, and we just pulled this from our medical record looking at and just this gives you, this is the instance of asthma and obesity, because you can look in Chelsea, and you can see as we get up here obesity, look at, it's running up here 30–40%, okay? Now we thought this was very high, and we had a small sample size, so we ran the same numbers in Framingham school entry, and we were seeing on the obesity side more asthma. So what we were seeing in our clinic, although very obvious, was a problem for everybody else as well. It's striking. It's absolutely striking in the clinic. Now, just to go back and look at this linkage. And so the problem with obesity and asthma, they're both quite common, so it's pretty important to look at large epidemiological studies. So I really went back and pulled the meta-analyses together because they pull enough numbers together that you can draw conclusions. Now this is really one of the best early meta-analyses done in 2007. This group, and literally in the study, they had 300,000 in the meta-analysis. So these are numbers that are enviable. I wish mine looked like that. And this is what they pulled out. And just to make it simple, they pulled a core of 7 studies but you can see the odds ratio is running about 1.5. That number has been preserved through many studies throughout. Now I'll just show you a couple. Now this, he also took it a little further here, what he did. Now just, this is broken up a little bit. Up here you see overweight. Okay, and each study looked at overweight and gives something and comes up with a BMI for overweight, and then greater than 30 being obese. Okay, so if you look, you see the odds ratio here of overweight is 1.38, and when you come down here, the obesity is 1.92. So you see a gradual. Just to explore this a little further, there was a follow-up study on this, which actually was done, this one here. This is the Norwegian study. And it looks at a large population, trying to understand a large population. And what they do here is they're looking at body mass index as a predictor of cohort. You know, and literally males and females are included. It's a Norwegian population. It's interesting, the definition of asthma here is the usage of asthma drugs. I did like the title, anti-asthma drugs. And the BMI was measured during health fair surveys. And changing BMI was looked at here, which is an interesting sort of concept for us. Now I'm going to what you call, it's a terribly busy slide, and I'm just going to get you to focus on the area that's red. Now, here is the BMI up here. You see the BMI just up here. Now, if you look here, and numbers are small, you're looking at a lower BMI, but still on the obese range, you get an odds ratio of 2.2. When the BMI is greater than 35, you get a BMR of 3.5. So you can actually see that there is weight. Now he presented it beautifully this way. This is looking at odds ratio. Sorry, this got squashed in the meantime. Now here you can see BMI rising and the odds ratio rising. So it did seem to follow a dose response curve. It did seem to follow a dose response curve. So so kind of held up. And I cannot come over here and not talk about Carlos's study in nurses here. And this is another way of looking at body mass. So again, relative risk, and this is not the high BMIs here, but you can see the relative risk does rise. Now all of them are rising into the same relative risk. They all run up in this range. So they're all running to about 2 is where most people are on the relative risk. So clearly a dose response curve, and it's there. Now, this one took it a little farther, and this is also in the early, this is in 1999, and you can see here, he looks at relative weight gain, okay? And what you see is way over here, in the underlined area just here. See, if you gain, these are kilograms, not pounds, so 10 to 20 kilograms, 20 to 25, and greater than 25. You can see the odds ratio 1.4, 2.1, 2.7. So you're seeing the dose response showing up in a consistent manner. As most of you know, I'm more of a chemist, so maybe I like it that way. Just you look for the dose response. So the dose response is showing. Now, there was initially very few studies done in pediatrics, and clearly my area here is pediatrics. Now, there has been, and as I put up here, pediatrics, the same story. And that's what is the take-home message. Pediatrics does have the same story. Now this is just to look at it, and this is a complicated study, and they focused on prospective studies. So and this is a meta-analysis, and there were 4 studies, 4 meta-analysis, 4 good prospective studies, and since this has come out, there's been a 5th prospective study looking at weight gain and asthma. Now, I don't want you to get this too busy, and I just want you to focus up here, and this is probably the busiest slide I've put up, but I couldn't shred it. But just look at the odds ratio up here. You can see that the pediatric odds ratio is running about 1.5, and remember I was taking 1.5 to 2. That's exactly the same as the adult. Okay. There is a bit more of a heterogeneous to the pediatric population. One of the studies did not show any effect, as 3 here and then 1 more did show an effect. So, but grossly there seems to be an effect in pediatrics, just like the adult world. Now, this paper, so why? The interest is, how does weight give you this? How does weight? Is it a more complicated? Is it complicated? Is it immune? Is it mechanical? Now, this is an adult study looking at bronchial responsiveness, and I know Stephanie will get back to this area a bit. But is it bronchial responsiveness? And this is a where the obese patients have surgery to reduce weight. So very effective, clear cut. Now the downside of this is numbers are very small. Numbers are very small. But they do look very well at metacholine challenge and airway hyperresponsiveness. And if you can see, now then they divided them into two groups. They divided into obese patients with asthma who have a low IgE and a high IgE. Now, I'm going to give you some perspective. Most of them are in the low IgE level. Most of them are low IgE. And so I would, to walk away, and you can see in the low IgE one, you can see they all improved from an airway hyperresponsiveness after surgery. So there's clearly an effect on the airway. Now, what effect on the airway? Is it allergic? As you can see me leading you up a little bit here, it does not seem to be allergic. Now this is so people wondered, could just obese patients have more allergy and that's the underpinning of all this? But this does not seem to be the case. Now this is one of the first studies to look at this in 2006. And I do remember Thomas Platts Mills coming and explaining that this might be more real in 1992 when I was a fellow. When he was discussing this and showing his pictures. So it's just interesting to talk about this, almost 20 years, more than 20 years later. Now here, I just want you to take a look. What they did here was, they looked and said, do they have allergic asthma or non-allergic asthma? And then looked at odds ratios. Now their definition maybe of allergic and non-allergic is not the most robust, but it was okay. It was okay. So here what they did was they said non-allergic asthma in men who have BMI or greater than 30 is 1.3, looking roughly like what we were seeing. And then of allergic asthma is 1.21, so significantly less. Now in women, it's more obvious. In women, you see it's 2.66 and the non-allergic. So what the take-home message is, it is more likely to be non-allergic. Now, and maybe that's the wrong word, but generally, the takeaway is non-allergic as we know it. Now, clearly I have pediatrics in mind. This study is worth a look, actually. This is a study from the Bronx, and where they take 120 obese kids in the Bronx, and they try to dissect what's going on with them. Now, effectively, what they did show, and I just wanted to show one slide from it, they showed what they did is they plotted against leptin the Th1, Th2 responses, okay? They also plotted against weight. Now, as you see, increasing leptin concentration, increasing Th1, okay? Increase one. So it was pushing towards a Th1 response, okay? Now, and then over here in the non-obese asthmatics, you see it going the opposite direction. It could be in the opposite direction. Now, I've cut this slide, so they did have healthy controls sitting in here as well, and obese controls sitting in here as well. So I've cut this slide. So effectively, this is a dramatic demonstration of a Th1 type response. The real issue from our point of view is, and this is something. The other thing that has been known for a while is obesity-related asthma has a tendency to be steroid resistant. Okay, it's well established in the clinics, and most people know about it. But generally, I want to look at it just briefly. Now, this is a study looking at signaling pathways in leukocytes, an area close to my heart, as some of these kinases are close to my heart. But just to give you an idea of what I wanted to give across here, you see this MKP, this is a phosphatase that regulates the MAP kinase pathway. What this does is it's one of the mechanisms by which steroids downregulate your immune system. Okay, so it's a marker of that. So if you look at it in detail here, you see in the asthmatic population, the MKP, if you're obese, you see the BMI up there is down. So you should be less responsive to steroids. So a different phenotype in some ways. Now here you do the controls, you don't see that. You just don't see that. So there's something wrong with the signaling that's going along here that's at a gross level. So just to sum up, what is this phenomenon? It does seem to be real, and we're seeing it in the clinics. What is it? And this is what my colleagues are going to get into later. So is it just an overlap of genes? Now, I don't believe it's this. Is it affected purely of lung volumes? Just reducing residual volume and giving stretch-related problems. I don't think that holds up. Although there is a literature supported, but I don't think that holds up in recent literature. Is it just chronic inflammation with TNF pushing you towards? That's certainly, or is it just the adipokines acting? So generally, the phenomenon is real. It's different towards classic asthma, and it appears to be immune. Probably Th1 is how you grow it from the gross level. I'd like to thank a few people that have helped me along the way. Christina Sirica on top, who runs the clinic, and Lael and Thimon, whom some of you know, and then Elsie Taveras, Obesity, who's also known to you. Thank you. And I'll pass to Steph.
So I'm going to just be talking to you about mice, about obese mice, and about the phenotype of obese mice. And I'm going to relate it to asthma. So I'm going to start by telling you a little bit about the fact that obese mice have what I call innate airway hyperresponsiveness, that there's no overt cellular inflammation in their lungs, that they do have increased allergen-induced airway hyperresponsiveness, but they don't have eosinophils. And they also have increased responses to ozone, which is another way to model asthma and another kind of asthma trigger. So when we started this work about 10 years ago, we started with this mouse here, which is an OB mouse. And it differs from its brother by exactly one base pair. And that base pair happens to code for a premature stop codon in the leptin gene. So leptin's a satiety hormone. So these mice eat voraciously. They have really low metabolic rates, and they're, as you can see, substantially obese even when they're 8 weeks old. So what do their lungs look like? Well, we measured airway responsiveness in these mice, and I'll just set you up. This is pulmonary resistance here, and this is methacholine on this axis, and the black circles are the lean mice. You can see increases in resistance as you give more and more methacholine. And in the obese OB mice, you see greater changes in resistance, so airway hyperresponsiveness. So over the years, we've done this in 4 different types of mice. This is a DB mouse. It has leptin, but it doesn't have the leptin receptor. This is a CPE fat mouse, which is lacking carboxypeptidase E, which is an enzyme involved in processing neuropeptides that are involved in eating behaviors. And these are mice that are on high-fat diets compared to chow control. So they're all obese, and in every case, the white circles are the obese ones, have airway hyperresponsiveness. So a couple of notes here. These mice either don't have leptin or don't have the leptin receptor. These mice have plenty of leptin. So in this case, it's definitely not leptin that is the answer to this story. All of these mice were studied with an open chest and with positive end expiratory pressure. So changes in FRC are not the answer, at least in our mice. The other thing is that all types of obese mice that are made on a C57 background have other problems. They're almost all insulin resistant, they're almost all hyperlipidemic, and those things could be influencing the response that we see. At least the hyperglycemia is not the answer, because when we give an anti-diabetic drug, metformin, we still see this response. Okay, so what about airway inflammation? So first of all, there are no neutrophils, eosinophils, or lymphocytes in the bowel of these mice. When you look at the airways histologically, you don't see inflammation around the airways. What you do see is some evidence of increased oxidative stress, and you do see low-grade systemic inflammation as opposed to airway inflammation that I'll say more about. When we first started this was kind of before people understood what they understand now about the fact that a lot of obesity-related asthma is non-allergic in nature. And so at that time, we were still thinking, well, maybe we could take obese mice and give them worse allergies by having them be obese. And so you can see when we did standard allergen models in mice, the obese mice do have greater allergen-induced airway hyperresponsiveness. They do have a greater ability to mount an IgE response, but they have very, very few eosinophils. And so here's the BAL eosinophils. You can see the lean mice, the black bar, have the typical increase in eosinophils when we give them allergen, but the obese mice, hardly any. And so when we first saw this, we thought, okay, well, maybe the eosinophils are getting stuck in the tissue, and they just don't come into the bowel. But when you look at the tissue, that's definitely not the answer. So here's the lean mouse, lots and lots of inflammatory cells around the airways, and here's the obese mice, hardly any. So we've done this in OB mice and DB mice, and other people have done it with high-fat diet mice, and these mice just don't get eosinophils coming into the airways. And this is kind of typical of what's seen in human responses. So this is a study from 2008. They took all asthmatics and they measured sputum eosinophils. So this is the log of the percent eosinophils, so it's a big scale, as a function of BMI. And what you can see is that as you go further and further out in BMI, so you get to the people who are more and more obese, you're less and less likely to find somebody who has high sputum eosinophils. Okay, so instead of using an eosinophilic allergic model then, we said, okay, well, let's use a model that might be more relevant. There's oxidative stress in the airways, there's systemic oxidative stress in obesity, and so we decided on a model that we had been using a lot in our lab anyway, which is a model of ozone-induced airway hyperresponsiveness. So for those of you who don't think much about this, ozone is a very common air pollutant. It comes out of your tailpipe and whenever there's sunlight. When there is high ambient ozone, emergency room visits for asthma go up. It causes asthma symptoms, including airway hyperresponsiveness. And instead of inducing eosinophils, it induces neutrophils to come into the lungs. And importantly, ozone, when it causes decrements in lung function, these are greater in people who are obese than in people who are lean. And it's the same in mice. So here is, again, airway responsiveness. Here's the lean mice with air and ozone. So you can see this sort of relatively small increase in airway responsiveness in lean mice. In the obese mice, you see they're already hyper-responsive, even with just air. And when we give them ozone, two things happen. First, their pulmonary resistance goes up. We don't have to give them methacholine, just the ozone will do that. It doesn't do anything to that in the lean mice. And then their airway responsiveness goes way, way up. So they have this much greater change in airway responsiveness. They also get more neutrophils. So the black bars are lean mice, and you can see that after the cessation of ozone, there's a gradual increase in bowel neutrophils. And in the white bars, you can see that that's much higher if you're an obese mouse. And again, this is in CPE fat mice, but we find this in all types of obese mice that we've studied. So how does this happen? We have been mainly focusing on the idea that the systemic inflammation of obesity, which is now sort of known as a very common component of obesity, may be involved. So adipose tissue, if you're obese, produces a whole bunch of things, including cytokines and chemokines, energy-regulating hormones, a variety of other factors, and even acute phase reactants that we typically associate with the liver. So the fatter you are, the more it makes, and these things spill over into the blood, and they get circulating through the whole body and can affect basically every organ, including the lung. So over the years, we've focused some on adiponectin, on leptin, and IL-6, but today I'm going to tell you a little bit about TNF and IL-17. So why TNF? Well, serum TNF is elevated in obesity, and exogenous administration of TNF actually causes airway hyperresponsiveness, both in animals and in people. It's required for other obesity-related responses like insulin resistance. And Kelan's going to tell you about some genetic studies that suggest a role for TNF-alpha SNPs in the obese-asthma relationship. So in mice, what we did was we took CPE fat mice and we crossbred them with mice that either did or did not have TNFR2, which is one of the two TNF receptors. So if the mice have TNF receptors, then they get airway hyperresponsiveness if they're obese. But if they didn't have TNFR2, then they didn't get airway hyperresponsiveness. So we saw this data and we were really excited. We thought, yay, there's TNF blocking drugs out there. We can treat all these people. And then we unfortunately went on and did the other TNF receptor. And in that case, the exact opposite happens, right? So here's our wild-type mice, our fat mice, greater airway responsiveness. Now you take away TNFR1, and everything gets even worse than it was before. All right, so lots of head scratching. And eventually, one of the things that we noticed that was different about these two mice was their IL-17. So in fat mice, bowel IL-17 is actually higher than in lean mice, and if the mice don't have TNFR2, then IL-17 in the bowel goes down. Whereas, if you don't have TNFR1, then IL-17 goes up. So the IL-17 and the airway responsiveness seem to be going in the same direction. So why IL-17? Is there any evidence that this could be playing a role? So it also is elevated in the serum in obesity. And exogenous administration of IL-17 also causes airway hyperresponsiveness. And it has been shown to contribute to other obesity-related conditions in animal models, including glucose intolerance and non-alcoholic fatty liver disease. So it could be playing a role in asthma too. So this is some data from Dale Umetsu's group that was published just last December. So they took mice, they put them on high-fat diets, and they got what we got. So you have chow-fed mice, and if you put them on high-fat diets, they get obese and they get airway hyperresponsive. And if they don't have IL-17, they still get obese, but you can see that now that airway hyperresponsiveness goes away. So there's clearly a role for IL-17. And when he looked at the source of where is that IL-17 coming from, it was not from classical CD4 cells. It was from a type of innate lymphoid cell called an ILC3. And I don't have time to go into details on the flow, but you can see over here that whether he used high-fat diet mice or OB mice, the mice had more of these ILC3s if they were obese than if they were lean. And we've also seen a role for IL-17 in the ozone-induced airway hyperresponsiveness phenomena. So in lean mice, no role for IL-17. But in obese mice, here's that great increase in ozone-induced airway hyperresponsiveness in the obese mice. And when you give anti-IL-17, it partially brings the response back. You'll notice that it doesn't do anything to this baseline change here. So what else could be going on? One of the things that we've noticed is that in obese mice, there's an increase in IL-13 and IL-5 after ozone. This is not an allergic model, this is ozone. And yet IL-13 and IL-5 come out. That does not happen if the mice are not obese. So is this important? When we gave anti-IL-13, here you can see that typical increase in neutrophils in the fat mice, and when you give anti-IL-13, that goes away. So this was a little bit surprising. IL-13 usually thought of as recruiting eosinophils. Here it's recruiting neutrophils. How could that be happening? Probably it has to do with this chemokine right here called MIP3 alpha, also known as CCL20. So you can see ozone induces that chemokine, and anti-IL-13 partially brings that back down. So this is relevant because CCL20 is the ligand for CCR6, which is on all IL-17 bearing lymphocytes, and IL-17 is known to be a potent neutrophil recruiter. So probably what's happening is that IL-13 is inducing CCL20, which is bringing in IL-17 cells, and they're recruiting the neutrophils. So what about airway responsiveness? Does it matter? So here's the lean mice. Here's air, ozone, and then ozone with anti-IL-13. Doesn't do anything. Not surprising, there is no IL-13. In the obese mice, that increase that you usually see in the baseline resistance with ozone totally goes away if you don't have IL-13. But the airway hyperresponsiveness is still there. So clearly there's something else that's important. And we initially thought that the IL-13 was coming from CD4 T cells. We've since done experiments where we get rid of them, and we don't get rid of the response. So the source is not CD4 T cells. We think that it's likely ILC2s, another class of innate lymphoid cell. So just in conclusion, we think that obese mice are a useful tool for examining the mechanistic basis for obesity-related asthma. And secondly, that the responses that we see in obese mice are not just more, they're fundamentally different. We see things happening in obese mice. We see roles for IL-17, we see roles for IL-13 and IL-5 that just don't exist in lean mice. And I would be very remiss without thanking everybody in my lab and my collaborators over the years, some of whom at least are present in this room, especially my current fellows, Joel Matthews, David Kasahara, Jeff Brand, Helen Cho, and our newest member, Luisa Ribeiro. And that's it for me.
All right, in concluding our talks today, I just wanted to give a little overview as to why genetics may play a role in terms of the obesity-asthma relationship. Okay? So why do we think that genetics might play a role? Well, we know that both asthma and obesity are complex traits. We clearly know that they run in families. And if you just look, for instance, body mass index, heritability estimates has been as high as 90%, asthma as high as 75%, and associated phenotypes for both of these things also have significant heritability. So what I'm going to do today is run you through several lines of evidence that might support a genetic relationship between asthma and obesity. These lines include Mendelian disorders in which asthma and obesity are potentially co-inherited per se, twin studies, just basically looking at the co-inheritance of obesity and asthma together, some linkage studies, family-based linkage studies as well, that may show co-localization of genomic regions. Some common candidate genes, we mentioned TNF-alpha, we'll talk a little bit about that. Some evidence from genome-wide association studies, and the last topic, of course, we always need to know what's new and fresh that's out there, and so I'll cover a couple of papers that have come out within the last couple of months as well. So, anybody in the audience know what this autosomal recessive disorder is, just based on this picture? No geneticist out there, I guess. This is Bardet-Biedl syndrome. And Bardet-Biedl is characterized first and foremost by obesity. Of course, that's the topic here. They all have retinal dystrophy, dystrophic extremities, primarily polydactyly, amongst some other structural abnormalities. And interestingly enough, this is clearly an autosomal recessive disorder, and it has a very high prevalence of asthma. I've looked at multiple case series of Bardet-Biedl, and in every single one of them, they are shocked to find that the prevalence of asthma is generally around 30%. Thereby suggesting maybe some co-inheritance. What about twin studies, and what can they potentially tell us? Well, there have been 2 twin studies looking at the differences in obesity-asthma relationship between monozygotic and dizygotic same-sex twins. In this case, this first study, it was published in 2005, you can see that there was a strong relationship in both males and females in terms of obesity leading towards a higher incidence of asthma. In both cases, substantial heritability was noted for both obesity and asthma. And using a variance component model, they were able to estimate that not just individually are these heritable, but about 8% of the overall traits were simultaneously inherited together. Okay? And this was independent of taking gene environment or causal intermediate hypotheses into account, suggesting that the potential genetic contribution at a single locus might be actually much stronger within these twins. Second twin study, the big difference between the first twin study and the second twin study is that in this particular case, females were noted to have a much higher odds ratio of asthma given obesity than males. This has been seen in many epidemiologic studies as well. And in this particular case, given that higher odds ratio, they also found that there was a substantially elevated odds ratio for obesity, for asthma in the obese females in the identical versus the fraternal twins. When they looked at the genetic liability or heritability of co-heritability of these disorders, it was actually about 28% in these individuals for females alone. Okay? So what about other family studies and history of family studies? these are old studies that we no longer really do linkage studies based on multiple pedigrees. But back about 10 years ago, these were very popular, in which case you use multiple tandem repeat markers across chromosomes to localize regions of genetic involvement. And back in 2001, we proposed the possibility that there were multiple genetic loci co-contributing to both asthma and to obesity. Here's the 5q chromosome cluster, the 12q chromosome cluster. Clearly, multiple asthma genes and multiple obesity genes have been mapped to all of those loci that I've indicated in red. As a way of pursuing this, we actually conducted a linkage study, conducted all in probands with asthma, but in families, pedigree families for body mass index in Costa Rican asthmatics, okay? The big thing to note here is we saw one very large linkage peak. It was significant with a LOD score greater than 3, suggestive of highly significant linkage. And this is a little bit small, but there's a locus right near the peak of that called PRKCA, which is protein kinase C, and the alpha form thereof. Because of that, we actually looked at the genetic association between PRKCA and body mass index in these probands with asthma. And within asthma, you can see that here is some association both in our CAMP Childhood Asthma Management Program as well as our Costa Rican cohort for these 2 SNPs and 2 additional SNPs over here that were strongly associated in these asthmatics for the body mass index phenotype. Just to prove that this was a pleiotropic gene, we actually went back and looked at variations in PRKCA for asthma as well, and again found in both the childhood asthma management cohort as well as the Costa Rican cohort strong associations with asthma in addition to obesity, suggesting that PRKCA can indeed help to simultaneously mediate both asthma and obesity. So what additional other positional candidate genes are out there? Well, actually, a lot of these have been studied in association with both obesity and asthma. You may have heard of the beta-2 adrenergic receptor. There certainly is literature surrounding that in both asthma and in obesity. Neuropeptide Y, there was a publication that came out actually last year looking at the joint association between asthma and obesity with neuropeptide Y. I'm going to talk a little bit more just about tumor necrosis factor alpha to follow up a little bit on what Stephanie was talking about today. Okay? So, when we look at candidate genes globally, if you look, there have obviously been a lot of genes associated with asthma, a lot of genes associated with obesity. If you look at the GeneCards database, there were 453 genes that actually have some annotation to both asthma and obesity there. A lot of candidate genes. In this interesting study conducted a couple of years ago, they looked at 22 genes that were associated with asthma in at least 3 independent populations. And then they said, wow, well, we have a large metabolic cohort. Why don't we test these genes to see if there's some association with metabolic phenotypes, including obesity, insulin resistance, and diabetes. And you can see of these 22 genes, 6 of them were actually associated with at least one metabolic phenotype, with 4 of them specifically being related to obesity. And the most consistent association was actually with tumor necrosis factor alpha. In a related study, the individual, in this particular study, they looked at the independent effect of tumor necrosis factor alpha on obese incident asthma. So basically, this is your overall odds ratio, in this case a little bit over 2, for having asthma given obesity. You can see that for the overall cohort, if you had the mutant allele, there was maybe a mild accentuation if you, in the odds ratios. And this, again, echoing what some of the prior speakers have said, really did not occur at all in the atopic asthmatics, but when you look at the non-atopic asthmatics, the odds ratio for having both the TNF-alpha mutant allele as well as having the obese state was all the way up in the 5 range. So dramatic increases in your odds ratio affect modification by the obese status on asthma risk. So let's switch from candidate genes to genome-wide association studies. Now, in this particular case, instead of looking at linkage peaks, these are GWAS signals for asthma and a variety of other metabolic features as well. And similar to what we reported with the linkage studies, these authors reported that there were multiple loci, and actually there were several others there that I did not highlight, that really localized very specifically to the same genetic locations for both obesity, obesity-related phenotypes, and for asthma. However, to date, there really has only been one genome-wide association study specifically looking at body mass index risk profile in those individuals with asthma and without asthma. And this was conducted by Eric Mellon and Jessica Lasky-Sue at the Channing. And you can see that in this particular GWAS study, they had 8,165 asthmatics, and they found a locus on DEN-D1B that was strongly associated with body mass index in the asthmatic cohort. Now, the interesting thing about DEN-D1B is that there were multiple other prior publications implicating DEN-D1B as an independent asthma locus as well. Okay? In a non-obese in the non-asthmatic children, when they looked for body mass index loci, they actually did not find a signal at D1B whatsoever, but they did find one in the related DEN-D1A locus on chromosome 9 instead. Okay. So overall, their effect for DEN-D1B across multiple studies really gave you elevated risk at the loci for body mass index again. And again, I mentioned that DEN-D1B has been associated strongly with asthma in other large cohort studies, again suggesting the possibility of a pleiotropic locus between asthma and obesity. Okay. So finally, to wrap up, let's talk about two novel studies that have come out just within the last couple of months. The first one, these authors, in an in-press article right now, they describe an inversion area, a large inversion area, about 119 kilobases on chromosome 16p. And what a genetic inversion is exactly what you think it is it takes a region of the chromosome and it turns it upside down. So that if you have a gene that is upstream, suddenly it is no longer in close approximation to a gene that is close to it, but it could be several hundred kilobases away now as a result of that. Now, these authors astutely noted that the 16p locus was also one of those chromosomal regions that had been previously implicated in both obesity and in asthma simultaneously. And they said, well, what happens if we look at the obesity-asthma relationship across multiple populations? And in this case, the inversion was relatively common. You can see that it's anywhere between about 20% and about 50% across the world. What they found is that initially they looked at the asthma association because of the proximity to prior asthma loci. And yes, indeed, this inversion was actually associated with a protective effect with an odds ratio of 0.82 compared to the lack of the inversion. Having said that, when they looked at obese asthmatics specifically, you actually see a doubling of that protective effect. So much, much lower risk of having obese asthma overall given the presence of this inversion allele. So the final thing I wanted to cover is a DNA variation, but actually nothing that has to do with DNA, that has to do with more methylation in the DNA rather than polymorphic variation in the DNA, otherwise known as epigenetics. And in this particular case, these individuals took 8 individuals from 4 different groups: obese asthmatics, obese non-asthmatics, asthmatics that were not obese, and healthy controls. They isolated peripheral blood mononuclear cells in all of these and extracted the DNA and conducted genome-wide methylation analyses on these individuals. And as a result of that, the lower right-hand corner in all of these plots show the obese asthmatics compared to either the normal weight asthmatics here, obese non-asthmatics, or healthy controls. And you can just see from these heat maps that there were strongly differentially methylated genes for all 3 conditions compared to the obese asthmatics. Okay? All told, there were 215 genes that were differentially methylated compared to all 3 of the conditions. So if you take the unison of all of those, and interestingly enough, amongst these are genes such as CCL5, TBX21, FCR2, and TGF-beta1. And at the Channing Laboratory, we've published on all of those genes and their association with asthma previously as well. So strong asthma candidates that are coming out as being also uniquely differentially methylated in obese asthmatics. These authors went on to also conduct some pathway analyses, and the important thing to here is that there clearly are differential pathways that are being regulated in obese asthmatics as compared to just asthmatics alone or compared to obese subjects alone. Certainly further work is needed in that area. So finally, in conclusion, there certainly are multiple lines of evidence that exist to support a genetic contribution to the obesity-asthma relationship. The associations that I've shown today don't take into account the potential for epistasis, meaning gene-gene interactions themselves, or for causal pathways, meaning that a gene leads to one condition that subsequently leads to another condition, which actually might heighten the overall genetic effects there. And certainly from a potential next steps, functional validation, additional omic studies, given the fact that epigenetic studies look so compelling in this particular case, looking at other transcriptomic studies might be very interesting, as well as further modeling in a systems context. So I'd also like to acknowledge the individuals at the Channing Division of Network Medicine who've been working in this area, and I think as a panel, we're happy to take any questions.
Terrific presentations and for saving us time for discussion and questions and interaction with the audience. And we'll also welcome questions for those who might submit them via their computer and live webcasting. Maybe I'll start with an epidemiologic question. I think the relationship that you focused on, Bernard, was one of increased risk of the development of asthma. Do we have any information on asthma severity, on risk of exacerbations, on frequency of hospitalizations and the like?
Certainly there's good evidence for obesity-related asthma being more difficult to treat.
Let's see this slide. I'm sorry. One more time.
There's good evidence that obesity-related asthma is more difficult to treat and less responsive to steroids, and that's backed up by hospital admission rates with it. And a couple of smaller studies look at that, and certainly usage of medications. So on the whole, the drugs have been particularly well designed for allergic type asthma, so I think it's just what we do. But it is more difficult to treat, and it's what we're seeing. It's actually what we see.
I was trying to think of the experience of the Severe Asthma Research Program, which has epidemiologic data on the descriptive data on the group of patients who have severe asthma. Is obesity one of the subtypes of the categories of severe asthma? Elliot, do you want to comment?
There's a subtype, category 3, which is older women who are overweight, who develop asthma later, tend to develop asthma later, and are very difficult to treat, and appear to be maybe less Th2, if you will. I was going to ask, though, there's a recent article that actually suggests that when we look, if we do endobronchial biopsies as opposed to just looking at sputum, that these obese asthmatics actually are fairly eosinophilic, which is a little bit surprising. And I wonder if you have thoughts about if there is really a Th2 mechanism in these people. Is your experience still that they don't respond well to current drugs?
So I think calling it Th2 might not be the right word. At least in our hands in mice, with ozone, we see IL-13 doesn't come out of Th2 cells. It might come out of ILC2s. And so it could be that there are eosinophils that are there. It could be that, though, that they're not coming for the usual reasons. They're coming because something has stimulated their ILC2s and caused them to release IL-13, which is recruiting eosinophils.
Stephanie, perhaps I could take a question submitted online here. It's, will only a high-fat diet but not over-albumin exposure-induced airway hyperresponsiveness in mice. And in obese wild-type mice on a high-fat diet after sensitization and challenge, are we going to see less eosinophilia compared to controls?
So I have not done that, but there are actually several studies in the literature that where people have in fact taken mice, put them on a high-fat diet, and then sensitized and challenged with them. And they see what we see, at least in the initial phases of the response. It seems like if you wait long enough, they do get eosinophils, but it takes days as opposed to hours for that to happen.
Barbara.
If you take the fat mice from the high-fat diet and put them on a low-fat diet and they lose weight, does their hyperresponsiveness go away?
So we haven't done that. Clearly in people,
If you get rid of weight, their airway responsiveness goes away, but we've never done it in mice.
Is there more than the one study, Bernard, that you
There is.
cited?
There's more than one study that shows that. It's, again, it's mainly adult. It really hasn't been done in pediatrics, in the pediatric type obesity that we see, which might be a different phenotype. So yes, it's begging to be done in pediatrics, but the adults are all consistent, and mainly because bariatric surgery is so successful. So it's a relatively easy study.
I was struck by the slide, I think it was you, Stephanie, showed that in people, the higher the body mass index, the lower the peripheral blood eosinophil percentage.
yeah, it was sputum eosinophils.
Sputum eosinophils, right. Is there a clinical observation that goes along with that? Allergists in the group, have you found that obese asthmatics are less likely to be eosinophilic asthmatics, or have we looked? Do they have less eosinophils elsewhere? Allergic rhinitis, sinusitis, is there any clinical correlate for obese and less eosinophilic?
So there are several studies where they've looked at obesity for other allergic disorders, and they don't see a relationship. So it seems to be something specific for asthma, and this sort of goes along with the idea that this isn't about changes in allergy, it's about changes in the lungs somehow.
Better to anticholinergic stimuli than they do than
So
other
we've
ones?
never done that. There is, as you probably know, a study in the literature that suggests that the mice have like elevated baseline resistance, and that is effectively treated with anticholinergics. In our hands, we do see elevated resistance, but it's simply because mice have smaller lungs. And when we've given Rho kinase inhibitors, which are pretty potent bronchodilators, we don't see any change in the baseline. We just see changes in the airway responsiveness. I don't know why they see what they see, and we didn't. One possibility is that I don't think they fixed the end expiratory lung volume. I don't think they opened the chest. I don't think they gave PEEP. And so their mice were probably breathing at really, really, really low lung volumes and may have had a lot of airway closure, which our mice don't.
Can I ask the clinicians in the audience, adult or pediatric, if you saw an obese patient with airway hyperresponsiveness and shortness of breath who didn't have eosinophilia, allergy, and didn't respond well to inhaled steroids, would you say they have asthma? Is that asthma, or is that a obesity with bronchial hyperresponsiveness syndrome? Or panelists?
Well, I've obviously put a lot of thought into this because they do show up, and so much so that when we have asthmatics, we routinely do IgE levels right now on asthmatics when they walk in the door, just assigned to find what pattern they're in. So I've got used to it. So I still think it's asthma. And I still think it's asthma. It's just a definition thereof. It's not the asthma that I have, but it's the asthma that they have. And I have I've thought about it because it matters to me, because if we're giving high dose and extra high dose inhaled steroids, we're promoting more stimulating appetite, so it does affect what we do. So it does curtail my steroid use, and so I tend to, I actually, the question, you know, we do give anticholinergics early and it's changing my management. So if we walk in and say IgE is low, so it is changing our management. There's only partial evidence to support that this is an effective strategy, but from a weight gain point of view, we have to avoid drugs, you know.
Benji.
I'm sorry I missed the beginning. The role of the upper airway and the relationship between obstructive sleep apnea and the development of airways, increased airways responsiveness as a consequence of that, or in conjunction with that. I'm wondering if you can give any insights as to how that relates to therapy. If you improve their obstructive sleep apnea, does that improve their asthma? And secondly, in the mouse model, have people looked at the relationship of upper airway mechanics and so on? Do mice develop a sleep apnea, for example, et cetera?
I can answer the sleep question a little bit. There has been studies looking at obese patients who were short of breath, and if you put them on a CPAP, they do better. They certainly perceptively less short of breath. They're perceptively less short of breath. The component of upper airway in the obese patients is complex. I don't know the answer to that question, how much the upper airway is playing into lower airway responsiveness, but do we see tracheomalacia in the obese patients that we never saw before? Yes, in all the patients we never saw before, which is predominantly thought to be pediatrics. So I think you've got a good point in that it might be a global airway response. But treating CPAP at night does improve the perception of shortness of breath during the day.
Are there any formal studies about airways responsiveness or
Not that I know of.
bronchodilator
Yeah,
response?
no, not that I know of.
So with respect to the mice, there are people who are greatly studying the whole concept of sleep apnea and obesity in mice and find relationships with sort of intermittent hypoxia. But just to sort of put another wrinkle in the story, intermittent hypoxia in and of itself may play a role in systemic inflammation, because that inflammation in obesity is thought to be related to hypoxia of adipocytes, killing adipocytes, and them then recruiting macrophages get activated, and you get the whole inflammation thing. If you have more hypoxia, you're going to have more cell death, and that's going to be perpetuated. So even though it might seem to be upper airway, it may in fact include a component of systemic inflammation.
Can I ask a sort of way out question? Do we know anything about the microbiome in obesity versus?
Yes, we do.
Oh, wonderful. What do we know, and would it be relevant?
So what we know is that it's different, and that if you go on a diet, you can change it back. And is it relevant? Well, I'll tell you in about a year. Helen Scho in my lab is actually doing those experiments right now. We already know that it matters for ozone-induced responses. If you don't have a microbiome, you don't respond to ozone. You don't get airway hyperresponsiveness, which seems strange. But may in fact relate to circulating LPS exacerbating responses to ozone. You can't have a talk at the hospital without the M word, right?
That's true. And there are also some human studies looking at asthma. I don't know the obesity side of things, but clearly there now appear to be some changes in the microbiome related to asthma. So it would be interesting to look at some point in time at that overlap, and to the best of my knowledge, it has not been done.
Terrific. Well, if there are no more questions, I want to thank the panelists for an absolutely fascinating discussion, and thank you all for participating. Take care.